I'm provided with CT scan axial section image through the chest, CT axial image through the chest, which shows that there are multiple ground glass areas seen within both lung parenchyma, two on the right side and one large ground glass area on the left. All these ground glass opacities show peripheral consolidations, suggesting of reverse halo sign or the atoll sign. Rest of the lung parenchyma appears normal. The lung volumes are normal on both sides. The mediastinum is central. I cannot see any other pathology on the provided single image. So the in short, the findings are of a reverse halo sign or reverse the ground glass areas with peripheral consolidations. So my differentials in this case would include that of angioinvasive aspergillosis or also vaginal granulomatosis, and other include bronchoalveolar carcinomas. All the reverse halo sign is seen in these different multiple conditions. So I would like to take the history of the patient. If there is any evidence, any history of nasal
no, there was no such history. There was no such history, just a history of 2 months of fever and cough and shortness of breath. Non-specific respiratory complaints for 2 to 3 months. Any other differential? And there were no other systemic. There are no like invasive aspergillosis patient is usually sick.
Immunocompromised.
Yeah, immunocompromised. So there is no such history as well. Any other differential?
So these consolidation areas of consolidation are some of them are more towards periphery of the lung, and if the history is chronic, 2 to 3 months, I would like to think of some pneumonias, cryptogenic organizing pneumonia, like COOP or the chronic eosinophilic pneumonias. However, if the history was short or acute, then I would think of the pandemic in these days, COVID. But as you said, it's 2 to 3 months, so this becomes less likely.
Yeah. So in the COVID, usually there are peripheral ground glass densities. Usually these curvilinear, or what you call it, atoll sign, is basically a ring shape area for airspace density with ground glass, and your differential description was excellent. And this is basically a case of organizing pneumonia. So reverse is basically pathognomic. It can be seen in other entities, but if you see the complete ring or C-shaped arc and densities, these are basically considered pathognomic. So they can, the other condition can have the ground glass densities, but the atoll sign, what we can describe, is usually more typically seen with cryptogenic organizing pneumonia than others. But other differentials does come in the differential. And chronic eosinophilic pneumonia, as you have mentioned as well, they're also they just have eosinophils in the blood, and appearance is more or less similar to the both. Good.
Provided images of the CT scan, axial and the coronal images showing there is multiple variable sizes cystic lucencies are seen involving the upper and lower zone, upper and middle zones, sparing of the lower zones, with the septal thickenings is also seen in between them, and on these findings, diagnosis of this case is Langerhans cell histiocytosis due to sparing of the base.
Okay, yeah. So basically there are some nodules, and most of them have cystic areas, and the key for these is basically irregular or bizarre shaped cysts, and more in the upper and with relative sparing of that. So that was good, but this was not the only thing which in this case. So it was a smoker. You have already said that the points. This is the older CT of the same patient, and there was CT abdomen as well. So can you further come up with something else?
Okay, sir. Provided images of the CT scan and abdomen. In the CT scan, there is a same cystic changes is seen in the upper and middle zone, and with the septal thickness and the nodular infiltrations. However, base is sparse. In the second image, which is provided from the CT scan abdomen at the level of the kidneys with IV and oral contrast, showing there is a hypodense soft tissue opacities is seen, which is surrounding the whole both kidneys. The cortex of the both kidneys appears thin, and also they showing enhancement on the post-contrast images, and
yeah. So there's some, it's hard to appreciate, but there's some diffuse thickening around the aorta as well.
Aorta as well, yes.
Basically bilateral perinephric soft tissue infiltration and some hydronephrosis. Along with, as you said, Langerhans cell histiocytosis in the lungs. Is there any combination or anything which you can point out to a more specific diagnosis? Because histiocytosis is a spectrum of disease, right?
Yes.
So anything else? There are cases of non-Langerhans histiocytosis as well. It's a difficult case, so I must appreciate that. So, but you have nailed the case and you have reached a right diagnosis. So there are histiocytosis which can be Langerhans cell histiocytosis as the CT chest findings were there. And then if it is more of a systemic disorder, not only involving the lung and kidneys and the retroperitoneal, even the other organs as well, orbit, and so that becomes non-Langerhans cells histiocytosis, as you have already mentioned. So this is basically a case of Erdheim-Chester disease. So I'm not sure if you. So I'll go through briefly through the cystic diseases of the lung just to describe, and as you have already mentioned. So Langerhans histiocytosis, as you said, is a smoker upper and mid lung zone because it's a smoking related. Any smoking related disease is more pronounced in the upper and mid lung zone, and they have multiple small cystic areas, pulmonary cyst. But the giveaway in this is the cysts are very irregular and bizarre shaped cysts.
Okay, sir.
This is another case of lung cyst. Pulmonary cyst. So do you know the difference between cyst and the cavity?
So this is another case?
No. I'm just asking, do you guys know the difference between the lung cavitation or cavity and a cyst? It's basically the wall thing. Yeah. So it's
so in the cyst, the wall is very thin, and in the abscess cavities, the wall is thick as compared to the cyst
wall. So 3 millimeter is usually the cutoff. So 3 millimeter and less is basically any cystic lesion or lucent lesion is considered a cyst, and anything more than 3 is cavity. So these are the other causes of the cyst. So these are more variable size, but not bizarre shape as we see in the previous. And the underlying lungs are otherwise normal other than the cyst, and this is if it's a young female patient that becomes
Lymphangioleiomyomatosis.
And it's homogeneous throughout there is no apicobasal gradient in this, so they can be seen upper, mid, and lower, and so these are the other causes of the cyst. So there are other rare diseases of the lung with the cyst, like LIP. Lymphocytic interstitial, but there is usually a Sjogren's or AIDS in this, and there are relatively fewer cysts and some interspersed interstitial changes like ground glass or reticulations in this. So this is the other cystic lung disease. Birdhoff-Dubé is one of the more rare. They are larger cysts in the base, and if there are skin lesions and renal tumor given in the history, then you can come down with this is a rare syndrome. And lastly, cystic bronchiectasis can simulate cysts as well. So usually they are branching opacities. But if it is large, very big cysts, then it looks like basically pulmonary cysts. But if you can see that these are tubular in the coronal or sagittal, then you can come down with the diffusion.
I've been provided with X-ray test or frontal projection of a clinically mature adult patient, showing that the ET tube is in its normal position with the tip at the sternoclavicular junction, and there is also ECG leads are attached. There is evidence of extensive reticulaenodular shadowing noted involving bilateral lungs, and there is no zonal predilection and no sparing of the peripheral regions or the postophrenic angles. The heart silhouette is giving a shaggy appearance. So based on these findings and the diffuse lung involvement, my top potential would be of alveolar microlithiasis. And next, I would like to proceed with an HRCT.
Okay. Alveolar microlithiasis is very rare, and usually in microlithiasis, you see those densities are very dense, like it's calcification or even higher. So, you have already mentioned that these are all interstitial changes within
Yes.
any other differential other than macrolithiasis?
So
Okay, I'll go with the second images as you mentioned, HRCT.
So these are fibrotic lung changes which are involving, which are causing honeycombing and predominantly involving the periphery of the lung basis. So this is a UIP, usual interstitial pneumonia, and
okay, yeah. So these are the typical distribution, more marked in the base, subpleural, and basal and postbasal, with honeycombing appearance. So honeycombing means basically it's a end-stage lung disease, and the typical pattern is UIP pattern. And so UIP can have many causes. The most significant is idiopathic pulmonary fibrosis, which is a diagnosis of exclusion. Once you have ruled out other underlying causes of the UIP, then you should not call anyone with this pattern right away the IPF unless you know that there is no very classic findings and you know there is no other underlying condition causing it. So because UIP, IPF is basically worse than lung cancer. Basically, it's giving someone a diagnosis which has only very poor prognosis. Okay, so this is one of the fibrotic lung disease pattern, and the other fibrotic lung disease pattern is NSIP, where there are more reticulations, less honeycombing and ground glass densities, right? And it can be fibrotic or non-fibrotic. When fibrotic, you can see some honeycombing and like loss of volume and friction bronchitis. This is the other pattern, different patterns of NSIP. So differential between NSIP versus IPF is like it's more coarse reticulation and very little, if any, ground glass and more chances of honeycombing. Though both are there in the lower lobe, and especially if you see the distending esophagus, then you consider that this is collagen vascular disease associated with NSIP, or NSIP can be idiopathic as well.
These are plain X-ray of a skeletally mature patient. First one is the frontal projection, and the other is the lateral projection, showing no abnormality is noted in the bilateral lung fields. Cardiac and mediastinal contours appear to be normal. Trachea is also central. Bilateral CP angles are clear. There's a serpiginous opacity noted superimposed on the left hilar.
Yeah, so this is a lobulated density here, probably here as well. I'm not sure if it is projected well or not.
So both the hyla appears to be bulky with the lobulated contour. And rest of the soft tissues and skeleton appear unremarkable. So concluding my finding of bilateral bulky hylia, my diagnosis was that be of sarcoidosis.
Okay. Yeah, your differential basically, it's a non-specific finding, right? Bilateral hilar lymphadenopathy is what you're trying to describe. So differential would be sarcoidosis, and there could be other differential as well. Although I did have mentioned that I won't show, but lymphoma is one of the differential, and tuberculosis can be a differential as well.
Yes, sir.
Yeah, metastasis could be, but it's a young patient, relatively less likely. Bilateral hilar. So what else would you do?
Further, I will go for CT chest to see as the both the hyla are symmetrically, there's symmetrical involvement of hyla. So I'm just considering the sarcoidosis.
Yeah,
and for even if we were ruling out other differentials, I would go for a CT chest.
Yeah. Okay. So that's the CT chest.
These are the axial and coronal sections of HRCT showing diffuse bilateral centrilobular nodules in both the apical segments of bilateral upper lobes with relative sparing of the lower lobes.
Yeah.
No other significant pathology is noted. There is also intra and interlobular septal thickening is noted. I would like to see the mediastinal window as well to see for the lymph nodes.
So there are lymph nodes in the hyla, as you said on the radiograph, and there were paratracheal lymphadenopathy as well. Yeah.
As well, so that the paratracheal lymphadenopathy and bilateral hylar involvement that goes to the lambda sign of sarcoidosis, and as well as the pulmonary findings of centrilobular nodules and inter-interlobular septal thickening also signifies the pulmonary involvement in sarcoidosis.
Okay. I mean, your diagnosis is correct. It's just that I just want to pinpoint the description. So in sarcoidosis, where do you see those tiny nodules distribution? Where is the pattern of distribution of those nodules?
It's basically subpleural along the fissures.
And what kind of distribution is this? There are three types of basically micronodules or tiny nodules distribution or interstitial nodules. Basically, there are three pattern of distribution. There is centric distribution, right? And there is perilymphatic distribution, and the third is random distribution, right? So, in sarcoidosis, what kind of distribution do you see?
Sir, it is basically along the pleura, perilymphatic.
Perilymphatic, yeah, excellent. So now I'll show you what does the perilymphatic look like. Basically, can you see this vessel? Lymphatics run along the vessel, right? So you see nodularity along the vessel here.
Yes, sir. Yes, sir.
Here you can see nodularity along the vessel. These are not branches coming off the vessel, right? So you can see here you see the vessel should come smoothly like this. Some of the vessels are smooth, but some of the vessels you can see nodularity along it. So lymphatic run along the vessels or bronchovascular tree. So that's where you are seeing all the nodularity. So this is perilymphatic. The other areas where the lymphatic goes is basically the fissure. So can you see the fissure here?
Yes, sir.
So fissure, you can see the nodularity along this. This is perilymphatic distribution. So along the nodule, you don't have to have all the vessel showing this. If you see the nodule distribution more than 10% of the vessels on your images or on your, so that is perilymphatic distribution. If it is less than 10%, then it becomes a random distribution. So perilymphatic is one pattern of distribution of interstitial tiny nodules. The second is random. If it is less than 10%, like you can 10 out of one vessel, you see only some distribution along the pleura, like pleural distribution, or along the fissure, that becomes random. And if you don't see any, that becomes centrilobular, right? So those are the, so perilymphatic distribution has a differential separate from random, separate from centrilobular. So centrilobular is more of an inflammatory infective. I'll just go through the distribution of the nodule so that you know what we are talking about. Okay.
Yes,
So perilymphatic nodular distributions along the vessel, bronchi, fissure, anywhere where the lymphatic runs, basically. Okay.
Yes,
So I've already shown you the so perilymphatic has a differential of sarcoidosis. The other differential would be lymphangitic carcinomatosa, but usually lymphangitic carcinomatosa has other associated features. Is either it is localized to one lobe or one region, or if it is bilateral, then there are effusion and pulmonary metastasis, and there are some other features as well. The third will be silicosis and Kohlberger. Okay, that's perilymphatic. And I've already shown you that these features. Silicosis is also one of the, but silicosis usually have axial calcification. Like lymphadenopathy is not that bulky and usually have rim-like calcification. And the third is a centrilobular nodule or but centrilobular when they coalesce with the bronchial or the bronchioli opacification, that becomes Steinbach nodule, and those are more of an inflammatory or infective etiology. So those are the three type of random. Random will be in the metastasis or miliary TB. Random will be two, and though both random are basically centrilobular nodule are more of airway disease because they are the bronchi which enters in the center of the secondary pulmonary lobuli. And perilymphatic are like a lymphatic disease, and blood vessel related is usually random, which is usually either biliary TB or metastasis. So their pathology, etiology, their appearance, everything is different. Okay.
Yes. I am provided with the chest X-ray frontal projection of an adult patient. I can appreciate that there is increased hyperlucency is identified in both of the mid and predominantly lower zones. And there is a prominent vascular marking in the upper lobes. However, both the lung volumes are preserved, and there is subtle blunting of the both posteroanterior angles, like maybe due to pleural thickening. And there is the cardiomediastinal silhouette appears to be normal, and there are degenerative changes identified in the bones. So coming towards the increased lucency in both the bases, this can be an alpha-1 antitrypsin deficiency, or this can be, it's very rare. The differentials will come of increased radiolucency. These can be emphysematous bullies bilaterally, and so it can be pulmonary emphysema, but it is more common in the upper zone. So my first differential would be alpha-1 antitrypsin deficiency.
That's excellent. And the other hyperlucent lung lesions which are in the base could be rare lesions. Alpha-1 antitrypsin is one of the main differential in this, and you nailed it. Birdhog-Dubé syndrome can also be in the more marked in the base. Other cystic lung diseases usually are either throughout the lung or in the base. So this is the CT chest of the same patient. And I'll just go skip this case because you have already, mashallah, identified on the radiograph. So CT will be, yeah, CT will be more of an academic discussion. Basically, there are basal lung emphysematous changes, which is much more marked in the base. And the reason most of the emphysematous causes are in the apex because they are related to the smoking. So paraseptal or centrilobular or those cases are more marked in the apex because the air goes and air is goes more in the lung. Apex stays there and does not clear easily from the apex, so more marked disease in the apex. But this is hematogenous. So the blood flow, usually any blood flow related disease is or heavier particle, they usually sediment in the base, so they are more marked in the base. So that's why it's alpha-1 antitrypsin.
Thank you, sir.
Mesoblastic nephroma. So mesoblastic nephroma are basically more of a hematoma of the kidney, and they are usually congenital renal tumor, or they more have solid component with necrosis. The other differential would be Wilms tumor, right? Wilms tumor, cystic degeneration can happen. Common things common. So the Wilms tumor can have cystic degeneration. So that could be the differential. So those would be the multicystic dysplastic kidney. And mesoblastic nephroma, I would consider less likely. They are more solid with necrosis. And cystic renal Wilms tumor. And another one is multilocular cystic nephroma. Multilocular cystic nephroma is one of the differential as well, which can be seen in pediatric population. And so you described this. I'm not sure if it is projected well or not. Can you see a cystic area here in the left lobe of the left lower lobe of the lung? The cystic area. I'm sure
Yes,
with a thin wall. With
thin
a thin
wall.
Yeah. So the large thin wall cyst. So what could that be, or what could be the differential for this?
It can be nematocele.
Yeah, nematocele can be a differential, but they're usually that big and without any consolidation or any such history would be unusual.
I would rule out abscess because there is no air fluid level.
Yeah, so abscess would be, the child would be very sick, and there would be so. So in a child, very rare in a 3-year-old child. So in the large, bulla it can happen, but it's very rare in a child, basically, especially if there is no such genetic history or something. So the other cystic lung lesion, which are the most common cystic lung lesion, which are common in the child, are basically CCAM. And the second one, which is what this is pleuropulmonary blastoma, basically. So this is a pleuropulmonary blastoma, which can have similar appearance as the CCAM. And you can see that there is multilocular cystic lesion in the left kidney, so basically replacing the left kidney, and the lung, large thin wall cavity or cystic lesion in the lung. So multilocular cystic nephroma has been associated with pleuropulmonary blastoma. So this is one of the tumor. This can be aggressive as well, pleuropulmonary blastoma, and so locally, this can be locally invasive as well, multilocular cystic nephroma. So this is what it is, basically multilocular cystic nephroma with a pleuropulmonary blastoma, which does have common association with it. Okay. So these are the MR. The one of the characteristic feature of the multilocular cystic nephroma are they are very pliable and soft, and they are known to herniate into the pelvic calyceal system. If they are small, especially, they can herniate into the pelvic calyceal system, and then they kind of grow and grow and grow within the pelvic calyceal system. This is one soft tumor. Okay, so these are embryonic neoplasm, and this is important to recognize blastoma because they can be misdiagnosed and can be managed as CCAM. And so anytime you see a cystic renal lesion and a cystic pulmonary lesion in a child, you should consider this diagnosis. Okay, if you see this, if somebody has shown you this MR and the CT, then you should drop it out. Like in the previous ultrasound, you may come up with a mesoblastic nephroma, but usually they are solid tumor or more have solid component with cystic areas within it, and they are more of hematomas of the kidney. But once you see this thin-walled cystic areas, which is just replacing the whole kidney, this this should drop out of your list. And then narrowing down, you can drop it. And mesoblasthic lymphoma is more of a congenital lesion. And if you see the lung lesion, then probably this would be the top ones which should come. Okay.